Hello, I am Dr. Kranti Seetamagari. I'm a practicing hospitalist at Atrium Health, Charlotte, North Carolina.
And I'm Marina Fiera. I've been hospitalist since 2002. I'm physician advisor, Six Sigma Black Belt. And currently I founded my consulting company. My expertise is improving quality, cost, and efficiency for hospitals and physician groups. And we're here at HM19 in beautiful National Harbor, Maryland.
Today we had a pretty good sessions, including the plenary session this morning, and we had updates in the sepsis, updates in CHF, updates in COPD, perioperative medicine updates, pulmonary critical medicine updates. It was really interesting to know all the new trends from the last 1 year to 2 years. So it's really good, and I'll be interested to know more about the plenary session that we attended this morning. So how did you find that?
I found it very interesting. So Dr. Mark Harrison, who is the president and CEO of Intermountain Healthcare, spoke about their experience about shifting from traditional fee-for-service into value-based payment system, and how they have to make some bold choices for the best care of their patients.
Can you elaborate more on what exactly he was trying to say? I think he showed a beautiful graph of the percentages.
Yeah, I think reality is, I think we as a healthcare industry historically have been focusing on managing illness, right? So we're taking care of the patients when they are very, very sick. And historically, not much have been done sort of upstream. What can we do to prevent them from getting that sick and getting to the hospital? He actually showed interesting graph. And when you look at what determines somebody's health status, 20% is genetics, nothing you can do about that. Yeah, 6% is access, but 37% of their health determined by their behavior. What they eat, what they drink, what they do or not do. But when you look at how much money we spend in US healthcare on that behavioral modification, it's 9%.
Wow.
So really, 91% is spent on taking care of the sick versus preventing that disease.
So 90% of all these trillions of dollars is going for services in the hospital, whereas only 9% is going for prevention in the community to prevent the illness from happening in the first place.
Not necessary. When you look at overall healthcare spending, about 1/3 is spent in the hospital. So the rest is still spent on taking care of the sick, right? Whether they visit an emergency rooms, whether they visit in the primary care physicians. Again, we see them when they're sick. So we need to take 3, 4, 5 steps back and identify those patients who are, due to their behaviors, at risk for developing illness, and what can we do effectively to intervene. And they've done some interesting work. I mean, he basically said that they have, several communities, and they did sort of research and development. They had one community that is urban with its problem. They had one community that's actually rural with its problem. And really, they're trying to figure out what can we do to effectively manage that population health.
So it's not one size fits for all.
Bingo. Exactly.
So you have to tailor to the needs of the local community.
Bingo. Exactly.
And incorporate all the local community leaders and
Exactly.
trying to make people more healthy and prevent these people from coming to the hospitals more often.
Exactly. But you also need to get support from your governing board, because still, 1/3 of your business is going to come under fee-for-service from care you provide to the hospital.
Absolutely.
So if long-term you make them less sick, you're cannibalizing yourself.
Exactly.
So you need to step back as an organization and basically agree this is the right thing to do. We may take financial hit short term, and that's okay, but long term we actually will see benefit.
Exactly. So you are making patients or people more healthier.
Yeah.
And you are making them pay less because they are healthy and they stay at home rather than being in the hospital.
Absolutely.
So it's a win-win situation for them.
For patients, but absolutely, I agree with you, because in the end, this is the right thing to do for the patients. But from my experience, that very few healthcare systems actually willing to make that move from fee-for-service, because as tiny as margins are, they're still making some margins on fee-for-service. And as Dr. Harrison said, somebody says we're going to ride this fee-for-service pony until it's dead.
Yes.
And we're riding. It's, by the way, it was horse before, it's pony now, it's going to be cat 10 years from now, but people are going to ride it.
Exactly.
So what they did is actually quite interesting, that they decided that they're going to invest in providing different care to their patients while they're on the top financially.
The whole theme for the plenary this morning was adaptability.
Absolutely.
And change.
Absolutely.
Along with the new changes that are going on in the healthcare, especially with the hospital medicine, the way it is moving forward.
Yeah.
So we need to adapt to these changes as well, and we cannot just be traditionally sitting idly and just, we cannot let this system run the way it is right now.
Absolutely. And he was very upfront saying that it's not easy. And if somebody like him says it's not easy with all the skills, expertise, experience, etc., it's not going to be easy, period. But I also like how he positioned hospitalists because, we're uniquely positioned, right? So we're in the middle between people who are really, really sick and people who are healthy. And when you look at our growing specialty, which now close to 60,000 people, we take care of 85% of patients. So not only we can control the hospital cost, we also can effectively control what's going to happen to those patients when they transition to post-acute. So having not just understanding patient goal, and he made it very clear that everything should start with us understanding patient goals.
Absolutely.
Then having holistic approach to treatment of that patient, but then having sort of transition and place to the next level of care. And this is where hospitalists really can make significant changes in quality of care we provide to our patients and total cost of care.
Absolutely.
I found it very inspiring.
Yeah, all these national leaders, he was part of senior administration in Cleveland Clinic, and he had a vast experience, and other national leaders who spoke this morning in the plenary, they had pretty extensive experience in the healthcare industry, and their ideas are really valuable for us.
Absolutely, absolutely. What about you? What were your highlights?
So I went to clinical updates. The most interesting one this morning I attended was the Sepsis Updates, and Dr. Patricia Kritek, she's the professor of medicine, pulmonary critical care division at University of Washington.
Husky.
Yes. So she gave an extraordinary updates on the sepsis. So the most interesting one I found this morning was from 2018 Surviving Sepsis campaign. Yeah, we all know that the sepsis definition has changed. There is no more CIRS criteria. Now it's all the dysregulation of the organ system. That's the focus on the sepsis definition. And 2018 Surviving Sepsis guidelines have actually recommended 1 hour sepsis bundle.
Which included what?
That included basically giving your IV fluids, giving your antibiotics within the first hour, and checking your lactates and all these things, blood cultures, pan cultures. But the problem with this 1 hour guideline was many healthcare providers and systems are trying to catch up to this 1 hour timeline, and with this restricted time frame, there are more chances of doing errors and unnecessary managements for these patients. So with these backlash, the Society of Critical Care Medicine this year, actually in January 2019, they released an update to this 1 hour sepsis bundle. They said it is not mandated now to do your sepsis bundle within the first hour, but it is preferred to do it just for quality purposes and quality improvement, but it is not mandated. So they are essentially saying you don't need to follow this 1 hour sepsis bundle. The reason they say that is they haven't found any significant mortality differences within the first hour 1 hour bundle versus regular care that you give to the patients. Yes, absolutely. The patient needs IV fluids, antibiotics as soon as possible. Everyone knows that. But there is no rush to do it in the first hour. So that's the highlight with this new update.
I also found, because I attended that session as well, I also found discussion about using the best tool to sort of identify sepsis or diagnose sepsis early.
Yes.
That the Surviving Sepsis campaign specifically does not provide any recommendations for which tool you're going to use. And she basically discussed few of them.
absolutely.
So one of them is SIRS, two signs of SIRS plus infection.
Yes.
Super sensitive, not specific. Then
SOFA scores and QSOFA scores.
QSOFA. See, I found also the discussion about QSOFA, which I found very interesting, that QSOFA is very specific tool. That's why it's bad for sort of early diagnosis, because you're going to unidentify a lot of patients.
Yes, it doesn't have much sensitivity.
Exactly. But it's very specific. But what I found very, very interesting, that QSOFA is a good tool to predict mortality when you apply it to patients who come through emergency room.
Absolutely. Yes.
If you look at those patients in ICU, QSOFA more than 2, less than 2 for them doesn't make difference, because they're in ICU because they're pretty sick.
Absolutely.
But those patients who actually come to the ER, this may be a nice, once you think that this is sepsis, maybe a nice screening tool to decide whether these patients really need to be in ICU or whether they can go to regular medical.
And the other interesting one was regarding the discussion regarding the IV fluids. So what would you choose? Whether you choose Ringer's lactate versus normal saline versus albumin and other solutions. So that was a pretty good discussion. And
What was your take?
So the take on that, so basically Ringer's lactate is ideal when compared to normal saline with the sepsis patients, except in patients with advanced liver cirrhosis. So in those patients, there is a chance that you could increase the lactate levels. So you should be careful with those patients. But in general, if you have availability of Ringer's lactate, it's preferred to be used. And there was one other attendee asking a question like, the patient's lactate is already 5, and can I give Ringer's lactate to this patient? Will the serum lactate level go up by giving the Ringer's lactate?
And what was the answer?
No.
Interesting.
You cannot, no, because the serum lactate, the levels that go high, so you don't basically increase the serum lactate levels by giving Ringer's lactate, so you can give it.
I actually have admission. Like I've been hospitalized for a very long time, and I took care of a lot of critical care patients. I've never ever wrote the order for LR.
Yes.
So I probably would change my practice based on that.
Yes.
But the evidence that sort of favor LR versus normal saline, basically when they look at, and actually wrote it down because I found it like, wow, this is interesting. So if you compare normal saline versus LR, there's actually decrease in adverse kidney events in those patients who use LR. Statistically significant.
Absolutely.
And again, as she said, like if I don't have LR available, and if I have an S next to me, I'm going to order that.
Absolutely, you have to take into other accounts. Like say someone is dehydrated and their sodium is already low, like 128 or 126, then obviously you'll need sodium. So you'll choose normal saline over LR. So you have to use the clinical discretion depending on each patient. This is not like one thing fits for all. But the trend is overall in the last 5 to 10 years, more internal medicine physicians, hospitalists are using Ringer's lactate.
The surgeon knew something that we didn't know.
So, usually the surgery physicians have to, they were using this for a long time, but we, medicine physicians, we were using normal saline, but now the trend is shifting. So we are also picking up on the Ringer's lactate. So we are going good with that. So that was one thing else.
I also found interesting, and I mentioned that when I was going through my training in 1999-2002, this is where an article came out about early directed goal therapy for sepsis. And it showed great improvement in mortality, and we all changed our practices. And now, almost 20 years later, to find out that study actually don't suggest that those patients that have early goal-directed therapy have improved mortality. What makes difference is if they get the IV fluids and IV antibiotics early. So I found that quite opening. What did you think about evidence for using steroids?
Yes, so that was another interesting question that popped up today. So regarding the steroids, the evidence as of now suggests that you can choose hydrocortisone over fludrocortisone, because most of the studies have been done on the hydrocortisone physiological doses. You can use that for sepsis patients, but there is no difference in mortality in 90 days. It will only improve the blood pressure for the time being in septic shock patients, but it will not, there is no difference in the mortality whether you use steroids or you don't use steroids. But in the short run, your blood pressure will be improved, and patients obviously with steroids, they'll feel better. So, you can use steroids. And I was asking Dr. Kritek regarding whether should I choose hydrocortisone versus fludrocortisone, and she was recommending hydrocortisone. The reason being is this was the one that was extensively studied with a lot of evidence. So that was one thing. And the other interesting topics that came about was regarding the use of vitamin C and thiamine. Is there a role for giving high doses of vitamin C or thiamine in septic shock or sepsis patients in the ICU? There was actually one single center study that showed that there was a significant improvement.
From 40 to 9% mortality,
Yeah, mortality rate actually improved. Actually, mortality rate reduced from 40% to 9% by using vitamin C and thiamine, but it was a single center study with a very small number of patients. So the take on that is there is no strong evidence for that to use vitamin C or thiamine, but if you still want to use it, they are cheaper and they are not really harmful with a lot of side effects. Yes, you can use it, but there is no compelling, strong evidence to use it.
And again, in the end, it sort of depends on your level of comfort with risk. I'm the kind of person that, especially if we're talking about somebody else's life, and understanding that vitamin C and thiamine are probably benign, but for me personally, I would like to see more evidence that there's no harm and some benefit of actually using vitamin C, thiamine before personally I would prescribe. But again, I think it's probably going to be personal preference. But she did say that it's probably not going to hurt, and if it helps, that's great. But the key is evidence are limited.
Absolutely.